Welcome to AETCM, the emergency medicine channel. Shall we start,
Yes.
sir? A 45-year-old female, a known case of myasthenia gravis, came to ER with complaints of difficulty swallowing and dysarthria since one day. Also complaints of difficulty handling oral secretions and breathing difficulty since today morning. On initial 10-second assessment, patient was...
Difficulty in swallowing, you have to clearly tell whether it is liquid or solid. Then others will understand what it is. What is the difference between liquid and solid? Difficulty in swallowing, liquid and solid.
Yeah.
What is the basic difference?
Mass. Solids will be more difficult.
If it is a mechanical obstruction, solid will be blocked. If it is a neurological problem, liquid will be blocked first. Okay. Later, everything will be same.
On initial 10-second assessment, coming to airway, patient was speaking in short sentences, patient had difficulty moving her tongue, and she had nasal twang of voice coming from nose instead of mouth. Drooling of secretions was noted, and immediately patient was positioned and suction was applied. An injection glycopyrrolate 0.2 mg sub-Q was given.
What is the action of glycopyrrolate here?
To reduce the oral secretions.
Why you are giving glycopyrrolate in this case? You know that it's a myasthenia case.
Yes.
What is the need of glycopyrrolate in this case?
If over medication, cholinergic crisis, excess
cholinergic crisis or myasthenic crisis. That cholinergic crisis you always treat with atropine. Or this what is it? What you told?
Glycopyrrolate. So arrangement for definitive airways was made in the view of risk of aspiration and impending airway compromise. Coming to breathing, respiratory rate was 28 per minute. Shallow breathing with use of accessory muscle was seen. SpO2 was 95, improved with 5 liter oxygen mask. On auscultation, air entry was bilateral and equal. Coming to circulation, BP was 120 by 75 mmHg. Heart rate was 92 beats per minute. Coming to disability, GCS was E4, V5, M6. Exposure was febrile. Adjuvants to primary survey, we took an ABG. ABG showed pH of 7.436, PCO2 37.4, PO2 77.4. Potassium was
PCO2 is
37.4. Potassium 3.4, sodium 142. Creat 0.65. Coming to CBC CRP, total count was...
What did you understand from potassium and sodium? If it is normal, suppose it is normal, means your lab is normal. No, I am not telling that value is normal. It is the lab is normal or stable lab. What did you understand from these two things? And what actions you should take? Potassium is low. What the action should be taken?
But correction should be,
because he is already having myasthenia problem, and that can aggravate by hypokalemia. Sodium, which condition sodium can be high? Here it is 142. That is unusual. Normally what you see is 138, 120, 139, 140. Middle. Okay. 144, 144.2.
142.
42 means it is on the higher side. So what will you suspect? Dehydration. The patient may be dehydrated. Maybe because of the aspiration, fear, they might not have taken any water. All these investigations are done with a reason. Okay, we cannot blindly tell everything is normal, everything is normal. There may be some reason behind every investigation.
Coming to CBC CRP, total count was 8.2, HB 11.6, platelet was 3 lakh and CRP was 3.2. Coming to sample history, a 41-year-old known case of myasthenia gravis, acetylcholine receptor antibody positive, was diagnosed 6 months back on tab pyridostigmine 60 mg.
Can become positive or negative in all cases?
It can be positive in 60% cases.
So mostly it will be up to 80% it will be positive. Some patients, they may not have any positive antibodies.
On tab pyridostigmine 60 mg TID, tab neostigmine 15 mg TID, and tab glycopyrrolate 0.5 mg TID, came with complaints of difficulty swallowing and dysarthria since...
Here also they are given this, glycopyrrolate for what?
So
counter
this
the
pyridostigmine and neostigmine has cholinergic side effects. Sludge can be to reduce the secretions.
Okay.
Now came with complaints of difficulty.
Some patients will go to bradycardia.
Bradycardia. Difficulty swallowing and dysarthria since 2 days. Initially started with difficulty swallowing food and water and has rapidly progressed.
What is the typical nature of difficulty in swallowing myasthenia gravis and other neurological conditions like 9th, 10th cranial nerve involvement due to stroke and all? Typical difference.
Here
You know that it is myasthenia gravis, so you believe that it may be due to myasthenia. Otherwise, when you are taking a general case, 9-10 cranial nerve involvement can also produce difficulty in swallowing. Myasthenia also can produce difficulty in swallowing. How do you differentiate?
Progressive worsening.
Initially, patient can take without any problem. After 2-3 gulps, then they slowly develop issues. They slowly develop difficulty. Okay.
Which was rapidly progressing, and as initially it was for water and food. Later she had difficulty handling oral secretions as well, and also nasal regurgitation of food from both the nostrils was seen. Also complaints of slurring of speech and has difficulty moving her tongue. No history of upper or lower limb weakness, no history of bowel bladder incontinence, no history of imbalance while walking, no history of muscle aches or muscle twitchings, no history of fever,
so
cough.
We are asking for muscle twitching, muscle ache, all these things. Myasthenia, you know that it is weak.
Muscle fasciculations can be seen in patient already taking cholinergic crisis. Okay. We can see muscle. Or motor neuron disorders we can.
What is motor neuron disorder? Myotrophic lateral sclerosis. What is that?
Upper and motor neurons affect motor neurons and lower motor neurons.
Neuron type of lesion in the same segment. Okay. So that you have to see the reflex and all. Here what will happen to the reflex?
Reflex will be normal.
It will be absent or reduced. Normal because muscles are weak, no? So you may not get the reflex properly. Muscles are, if they are in good position, good this one working condition, then you will get a reflex.
In this case, there was no weakness, so muscle reflexes were normal. No history of fever, cough, or dysuria. Infections can cause myasthenia.
So infections are the most common thing can produce myasthenic aggravation. Okay.
No history of drug
drugs can be produced myasthenia deterioration.
Drugs, anticonvulsants.
Common things.
Beta blockers, calcium.
Common things.
Antibiotics.
Aminoglycosides. We give for everyone, no? So any fever, they give aminoglycosides or azithromycin. They all can produce fluoroquinolones. They all can produce myasthenia aggravation. So we have to be very careful. Beta blockers and all, some patients are taking that also should be taken care of.
Coming to CNS examination, patient was oriented to time, place and person. GCS was E4, V5, M6.
What will happen to GCS in myasthenia?
Normal. Coming to cranial nerve examination, it was normal. Coming to motor.
What happened to cranial nerve examination in myasthenia?
Ptosis can be third nerve.
It can involve. That is the thing. You have to examine properly. Ptosis on repeated movements, you can get ptosis. So we have to ask the patient to look for at least 1 minute up. So slowly you can see that eyelids are falling.
Kogan lid twitch.
So initially, when you examine on one time, you may not understand that. But if you ask the patient to keep that in position, eyelid, so slowly it will come down.
Coming to motor system, bulk was normal in both bilateral upper.
Eye movement? Did you check eye movement?
Yes, sir. It was normal. No ophthalmoplegia or
ophthalmoplegia is okay. That is very common.
Coming to tone, it was normal in both bilateral upper and lower limbs. It's then coming to power, we have to check all the muscles power, and it was normal in all the muscles. Coming to reflexes, it was normal, sir. And we checked a single breath count. It was 8 initially.
Single breath count is not single
test.
We have multiple tests to be done and documented. Suppose first is 8, then next after half an hour, if it is coming down, then you have to be very careful.
Coming to CVS examination, S1, S2 was heard and no murmurs was heard. Coming to RS, air entry was bilateral and equal. Coming to GI, abdomen was soft and non-tender. Now patient was given O2 via facial mask, 5 liter oxygen was given, and patient was maintaining saturation of 99%. Suction was applied for secretions, and nasogastric tube was inserted to avoid aspiration. Now serial ABG was taken to rule out any hypercapnia, and neurology consultation was given. After seeing the patient, the neurology had planned for plasmapheresis. Total 5 sessions of therapeutic plasma exchange was given. The patient tolerated well and showed remarkable improvement. After plasmapheresis, SPP was around 24. And we took a CECT to chest to rule out thymoma. It showed an anterior mediastinal soft tissue mass. Okay. So she was planned for further surgery once the patient becomes stable.
Okay. So this is a thymoma-induced myasthenia and coming with myasthenic crisis. Myasthenia gravis is an autoimmune disorder affecting the neuromuscular junction characterized by various degree of weakness of voluntary muscles caused due to circulating autoantibodies that blocks the acetylcholine receptors at the postsynaptic neuromuscular junction, inhibiting the excitatory effect of the neurotransmitters. It can be idiopathic autoantibodies What can resemble this condition routine clinical practice?
A snake bite. Coming to clinical manifestation, hallmark is muscle fatigability, fluctuating muscle weakness which increases by exertion, mainly affects the muscles which are controlled voluntarily. It can cause dysarthria, dysphagia, ptosis, diplopia, nasal sounding speech and worsening muscle weakness. Facial muscle weakness, bulbar muscle weakness, neck muscle, mostly flexors are affected more than extensors, and respiratory muscle weakness, weakness of muscles. Respiratory muscles and diaphragm is seen, which can result in CO2 retention, hypercapnia and respiratory arrest. Patient may lead to a respiratory arrest. Coming to investigation, old method, Tensilon test was...
classification of Wassermann's.
Wassermann's classification is divided into 4 classes. Class 1, only ocular myasthenia, only ocular symptoms like ptosis are seen. In class 2, ocular myasthenia plus some skeletal or bulbar weakness can be seen. In class 3, it is a rapid progression.
Bulbar weakness means what?
Dysarthria, dysphagia and difficulty chewing.
Okay.
In class 3, there is a rapid progression of weakness. Within 6 months, there is a rapid progression and myasthenia crisis. Like this case, it was diagnosed 6 months back and there is rapid progression. Okay. Class 4 is very late and severe. Coming to investigation, in old age, we used to do this Tensilon test, which is not done nowadays. Usually, we'll use IV adorphonium bromide, 2 mg. First test dose is given, then we'll give 8 mg after 30 seconds. You should always keep atropine loaded and ready because it can cause side effects. Now, muscle power might increase in 20 seconds and persist for 2 to 3 minutes.
So, you give atropine, immediately patient improves. That means it is myasthenia. If that doesn't happen, it is not myasthenia. It is a very simple test. But nowadays, we have better tests, so we don't do it. But in still peripheral hospital, they practice this.
Other tests includes...
But there is another thing, when the patient coming with myasthenic crisis, you can actually try this.
To differentiate between cholinergic and myasthenic crisis. Antibodies testing has to be done. Usually in 80% cases, we'll see anti-acetylcholinesterase antibodies. In some 38 to 50%, we'll see anti-muscle specific thyrokinase receptors. Some are seronegative myasthenia gravis. Coming to electromyography, it is a single fiber electromyography which records the action potential of 2 muscle fibers innervated by the same motor axon.
What is typical pattern?
First
incremental weakness.
Incremental weakness.
With every teaching, it slowly comes down.
It's called jitter and seen in myasthenia. Repetitive, like you told, repetitive stimulation can cause a decremental response. CT chest has to be done to rule out thymoma. Coming to management, the main goal is to maximize the activity of...
What is the other one? Etten-Lambert syndrome.
Seen in
elderly individual, Etten-Lambert syndrome is a differential diagnosis for myasthenia.
Usually seen in small cell carcinoma, lung
Okay, it's mainly
carcinomas.
seen in lung
Lung
carcinomas.
carcinomas.
Then, how do it different from this myasthenia?
Of
What?
The stimulation will exhaust the muscles.
Yes. Huh.
no.
Initially, that will be weak. Then slowly it will improve the power. Whereas myasthenia, initially it will be powerful. Then slowly it decreases. Same like here also in nerve conduction study also. The electromyography also you get same response.
Management will give acetylcholine receptors inhibitors like pyridostigmine and neostigmine. Dosage of pyridostigmine is 30 to 120 mg every 6th hourly. Neostigmine is 7.5 to 30 mg every 6th hourly. You have to look for muscarinic side effects, and glycopyrrolate should be given for the same. And differences between myasthenia crisis and cholinergic crisis. In myasthenia crisis, it is due to under medication. In cholinergic, it is due to over medication. Myasthenia will see tachycardia. In cholinergic, will see bradycardia. Respiratory distress is seen in myasthenia crisis, but respiratory depression is seen in cholinergic crisis. Pupils will be normal in myasthenia crisis, but in cholinergic, miosis will be seen. BP will be normal in myasthenia, but cholinergic will see hypotension. Other management include.
How do you differentiate?
When a patient comes, first we'll have to give edorphonium.
Edorphonium,
If a patient is reacting to that, is symptoms becoming better, then it's a myasthenia crisis. Not becoming better and patient is developing more secretions, lacrimation.
Then what you give?
Then atropine has to be given.
Atropine or glycopyrrolate. Try, then that will come down. Okay.
Then
So
other
that is still edrophonium is still they are using. Edrophonium or what will edrophonium?
Neostigmine also can be given.
Neostigmine also.
Usually
Edrophonium is a short acting.
Other management include thymus surgery for thymectomy, plasma exchange to remove the antibodies.
In acute condition, it is always plasma exchange.
IV immunoglobulins, usually IVIG 2 gram per kg is given over 2 to 5 days.
Okay.
Then steroids and immunosuppressants like azathioprine, myclophenate, mofetil, cyclosporins and tacrolimus also can be given. Drugs that are coming to drugs that are contraindicated in.
That is very important for it. There are some drugs contraindicated we routinely use that we should avoid, especially when you are intubating the patient, when you are trying to ventilate the patient. You have to avoid certain drugs.
Coming to anesthesia, patient, we should usually avoid using neuromuscular blocking agent. Already some patients will be in paralysis, so some patient does not require neuromuscular blocking agent. Even if given, we have to give succinylcholine, and for reversal we have to give Sagamedes 2 mg per kg.
So normally it will not reverse, you have to give reversal agent. That is the only issue.
Usually for induction, we'll give total intravenous anesthesia, which includes both propofol and remafentanil. Coming to other drugs which are contraindicated are anticonvulsants like phenytoin.
Vicuronium, all are contraindicated.
Because it very sensitive and can cause respiratory depression.
Okay. If you are intubating, there is no issue. But to reverse again, it will be very difficult.
Coming to crisis, it is an exacerbation of disease, myasthenia gravis disease, characterized by severe generalized muscle weakness and respiratory bulbar weakness that may result in respiratory failure, usually exaggerated by either by drug incompliance or by infections.
Most common thing is infection.
And primary treatment in myasthenia crisis is plasma exchange.
Role of steroids?
Steroids are also used.
There is no much use. Immediately you can give some relief. That's all. There is no major relief. Anything else you want to add? Nothing. Okay. Thank you.
Thank you, sir.